Hi, my name is Chelsea Shea. I am currently a student at Excelsior College that will be graduating in the next month with my Master's of Nursing in Nursing Education. This presentation is a summary of my capstone project entitled Stroke Education for Nursing Staff while preparing for primary stroke center certification. I have been a paramedic for the last 30 years. The last 17 years, I've also been a registered nurse. I have worked in the emergency department pretty much my whole entire career. I had a couple of little rabbit trails that I took into employee health. I've worked a little bit in surgery, and then I also took a job as house float. That was an interesting adventure, but I always came back to the emergency department. I also work in nursing professional development, doing education with the new nurse grads that have just gotten off orientation, offering another layer of support before they're on their own. I do in-services for the night shift, and then I also am now working with the stroke team to develop an educational program for our staff and develop in preparation for getting our primary stroke certification this fall. So the intent of my project was to determine the best method for stroke education for our nursing staff. I developed several presentations to use in the education program. At a later time, I'll be adding interactive slides using Adobe Captivate in order to measure the learner's retention of information presented in the PowerPoint presentations. Last year, in 2017, the entire nursing staff was required to complete the NIH Stroke Scale online certification program. The staff did not receive any practical training after the online certification process. The staff has expressed frustrations that they failed to see how doing this 4 to 8 hour test program, it depends on how well you did because you got to get like a 96 to pass the thing, how that really correlated into taking care of their patients. So the stroke education program is going to seek to get the staff to be able to correlate the online NIH stroke scale certification to their real life patients. In addition, they're going to learn how to perform the NIH in a systematic way so that the scores they record are comparable to assessments performed by other members of the stroke team. And they'll also learn how their scores correlate to monitoring the patient's condition as it improves or declines after TPA or another treatment is performed. So Tennessee is located in the stroke belt of America, meaning that there's a very high percentage of stroke deaths in our area. Our hospital is located right about in here. So we're right in the heart of this stroke belt. So in 2017, the hospital saw over 486 patients with stroke being listed as their primary or secondary diagnosis. This number included patients admitted through the emergency department as well as patients that were inpatients that when they began to experience stroke symptoms. Of all these patients, only 10 reported with acute hemorrhagic stroke, whereas 476 of the patients were acute ischemic strokes. So you can see our hospital falls right down on what the rest of Tennessee is doing. And really, if you look at the nation's stats, the nation as well. So our stroke education program is going to include one lecture I have is on strokes, the different types of strokes, pathophysiology of the strokes, and different treatments that the nurse may see. We'll also have one that talks about the BFAST exam, assessing the patient's balance, their eyesight, facial droop, arm weakness, slurred speech, and time last seen normal. This will also be taught to pretty much all the staff, but right now we'll be doing pretty much with the nurse techs. We'll be taught that along with the nursing staff. And then the nurses also learn, of course, the NIH stroke scale. This is another lecture I've got where we can go over each individual item and talk about how to score them. They've seen it already online, but now we're going to talk about it again. And then later we're going to do hands-on assessments. And then also teach them about modified NIH that you can do for your neuro checks as long as there has not been any change in patient condition or change in caregiver. Every time you give patient care over to another professional, you need to do an NIH scale so y'all can discuss what's going on with the patient and you both are on the same page. And then also the final one will be on TPA administration, including the monitor of patients after the administration, especially on blood pressure. And blood pressure will be covered both in both in hemorrhagic and ischemic, how important it is and how they need to be very proactive for their patient. So the online NIH stroke scale certification will be required for the emergency department and intensive care nurses. The other departments will be encouraged to complete it. We have something called a nursing employee incentive program that by doing, there's certain things you've got to do, and if you do all these things, they're education-wise, or doing community service that's sponsored by the hospital, you actually get up to $1.25 extra an hour. So a lot of people want to do that. So, and the reason that we really want to encourage all this is that there's a study that showed that when nurses complete the NIH online stroke scale certification program, plus they do the online computer-based learning modules as well as hands-on mock codes, over 85% of the staff had adequate knowledge of stroke and stroke assessment. Prior to this education, it was found that mostly only about 50% of nurses had the proper stroke knowledge or how to do an assessment. So after they get done with all the online certification stuff, we go over all the lectures in class, then we will have time to actually practice the NIH stroke scale in a simulated environment. We don't have the fancy mannequins that we'll use real people that will have scripts to respond to what the nurse asks and to respond to what to the different tests that they're doing so that it reflects what the nurse may see in real life. So groups affected by our patients are, of course, members of the stroke team, the emergency department, EMS, neurology, radiology, laboratory, respiratory therapy, pharmacology, just about everybody in the hospital in some way can be related into the stroke team. And then, of course, the patients and their families, because they'll be their education and their treatment is directly affected by how their staff, how their caregivers are trained to respond and care for stroke patients. And then the community, we do a lot of community outreach where we can be teaching the community about different comorbidities that make you more at risk of having a stroke, how to recognize stroke, and that how important time is for getting to the hospital, that to call 911, don't drive. So when we talk about implementing the project, we talk about some theories of where we came up with some of our ideas on how to do this educational program. So Patricia Benner had 5 levels of nursing. They were novice, advanced beginner, competent, proficient, and an expert. Now, a nurse that doesn't know these levels would still move through them because they're all based on experience. That's what the prerequisite is for achieving the expert level of nursing practice. So as a nurse starts out, she'll be a novice, have a novice knowledge of stroke and stroke assessment. And as she gets more and more, or he or she gets more and more experience, they will move up the ladder with their knowledge to being an expert nurse, and hopefully they passing on their knowledge to the next crew. So stroke education does not end in the classroom. A nurse continues to learn throughout their career. Mentors are an important part of the nurse's development of learning proper stroke assessment and care. This program is going to employ mentors who enjoy working with the novice nurses. The desired outcome for the students and staff that complete the stroke education program is of the confidence and competence that they can assess and score the NIH stroke scale correctly and can provide evidence-based care for their stroke patients. An experienced nurse who is willing to act as a mentor and take the novice nurse under their wing allows for them to move smoothly through Brenner's levels. A mentor can assess the novice's knowledge and ask the mentee nurse what do they feel is their strengths and weaknesses in performing the NIH stroke scale. So good leadership is not a prerequisite for management, but in order to facilitate a change, a leader has to assess their leadership ability. A leader has to take into consideration their influence on others. As a leader on the stroke education team, nurse mentors have to be cognizant of their influence on the staff that they are teaching. Educators will be directly involved with teaching nurses to perform the NIH stroke scale, as well as teaching less experienced nurses to use the ways of knowing to provide a clear picture of what is going on with the patient experiencing the stroke symptoms. Barbara Carpier identified 4 fundamental patterns in the ways of knowing. These patterns include personal knowing, empirical knowing, ethical knowing, and aesthetic knowing. Using the ways of knowing, a nurse's knowledge develops as they acquire more experience caring for their stroke patients. Nurses first rely on empirical data that is tangible and can be reproduced. The other ways of knowing develop from a nurse's personal experiences with stroke patients and continues to evolve throughout the nurse's career. At the center of stroke education is an improvement in the patient's safety and positive outcomes. Using a well-organized, systematic team approach to assessment and care will help ensure a well-organized approach using protocols and order sets that go into effect when a possible stroke patient is identified. Routine use of pre-printed orders can increase the likelihood of appropriate treatment due to reducing the likelihood of redundancy or omission. In order to measure improvements in the stroke assessment, a quality improvement tool such as the American Heart Association's Get With The Guidelines Stroke Program can help. Hospitals that utilize a quality improvement initiative strategy, tools such as printed protocols and order sets show higher rates of improvement than hospitals that do not use pre-printed orders. This can increase the likelihood of appropriate treatment due to reducing the likelihood of redundancy or omission. So these are some of the forms that I've got drafted to keep in our stroke reference manual, our notebook that goes to the patient's bedside whenever we've got a possible stroke. Talks about some of the things that can happen that we might need to stop the TPA and treat for allergies or increased bleeding. Then we've got the inclusion criteria for TPA, the exclusion for TPA, what treatment we need to initiate for ischemic strokes, what we need to do for hemorrhagic stroke, and how we need to be proactive in treating the blood pressures and what drugs we can anticipate being asked to give. And then this is a form that we can use. It's not accepted yet, but that we can use to keep the times of arrival when the patient goes to CT, when the doctor was there, when the neurologist was there, so that our stroke coordinator can use this to as a quality improvement tool to measure how we're doing on this program. These are two forms that I found. They haven't been accepted yet. Right now we're doing our calculations by hand with a equation. These are two dosing tables that I found. One, of course, in the TPA website, and the other one is actually from my husband's hospital where he works, where all you've got to do is just find the patient's weight, and it pretty much mindlessly tells you what you need to do. This is basically we've all probably seen this, the timeline to when we need to get things done for a patient that's experiencing strokes. This is a form that I've come up with that it's in a big drafting form. We haven't accepted this one either, but we're working at it, and this will probably have to be edited some. But we have places to keep vital signs and neurochecks, and then this is the exclusion criteria, inclusion criteria, the pre-TPA checklist, and then just some more room on the back. So nurses have always been patient advocates. Nurses are at the bedside way more than any other provider. We coordinate care. We bring to the attention of the doctors any changes in patient condition. And we also ask ourselves what causes patient most likely to have a stroke, and how can we help this patient avoid future strokes in the future and improve their recovery. Some of the objectives and goals for our nurses of stroke education are to be familiar with the types of strokes and their treatment, to be able to explain why the NIH is a good tool to use for evaluation of stroke patients, and to become more familiar with assessing the patient using the NIH, and describing the 11 items of the stroke scale and how to score them. And then how to perform an NIH with the prompting of an assessment aid, such as an app on their smartphone, or the mentor giving them clues and helping them along to do the stroke scale. We'll evaluate. We're going to do an evaluation prior to starting the education program, and then after the program, we'll also measure our door-to-drug times, and hopefully they will improve as the stroke program becomes more implemented. So we've got a lot of work to do before the Joint Commission comes in November. The first step we've got to do is we've got to identify where we've got to improve. So that's what we've been discussing in the stroke meetings every month. As November moves closer, our hospital will enter the part of change where we'll be implementing those changes into practice, and by November, those changes should be evident in our stroke progress. So in conclusion, November 2018 is approaching quickly. Um, and as we get closer, our preparations for primary stroke certification are going to intensify. Nursing professional development has received a lot of positive feedback from what we've done so far. And we believe that we're going to see an improvement in our stroke knowledge and our patient outcomes as a result of these changes. Thank you very much. I hope you've enjoyed this presentation.